Begin our first session. With great pleasure and happiness, I would like to introduce the leading lady behind the scene for this seminar, Dr. Julia Fraser. Dr. Fraser is executive team member of Asia Links and founding co-director of Asia Australia Mental Health, directing a wide range of Asia-focused initiatives within Australia and in the Asia Pacific region. As co-director of Asia Australia Mental Health, Julia works to support Asia Pacific mental health leaders to adapt global best practices in mental health service to fit with current socio-economic and cultural context operating in their countries. Her expertise is in planning and implementing wide change that includes large-scale project management, government and key holder relations, and developing training curriculum and programs for a wide range of audiences. It is my honor to invite Dr. Julia to take over the session, please. Thank you.
Thank you, Garima, and thank you all of you for coming, because we're just so thrilled that you could take the time out of your very busy lives to do this today. I wanted to call this seminar Depression, Everything You Wanted to Know but Was Too Frightened to Ask, because I think we're going to be presenting things to you, but I think I want to make this as interactive as possible. So please, there'll be time when you can, we'll try and keep this short as possible, the presentation short as possible, so that we can actually get your voices into this and get you discussing this with us. Because after all, the theme is depression. Let's talk about it. Okay. So let me tell you a story. A long time ago, there was a politician called Jeff Kennett in Melbourne, and he was very, very shocked at the rate of depression. And as a politician who worked with business and with others, he convinced government across Australia to set up a national depression initiative that has touched the lives of thousands of people, not only in Australia, but in China and across the world. So we're very thrilled that our previous Prime Minister, Julia Gillard, I don't know if you've heard of Julia Gillard, some of you have, is taking over the role of chairman of Beyond Blue. So that's pretty exciting. The other thing that happened was one of our key politicians, who is business-minded, Minister for Trade, done all the bilateral and multilateral trade deals, was very open about his battle with depression. He recently stepped down to follow other interests apart from politics. He stepped down in February 2016. And as you can imagine, many organisations wanted Andrew Robb to be their chairman. And you know what? He chose AsiaLink, our organisation, who is part of Asia Australia Mental Health, above so many of them because of the work that we do in combating mental illness and working with people and leaders such as yourself. Andrew was coming to talk to you directly. Unfortunately, his reputation with politicians and friendship with the Prime Minister meant that, I've forgotten what day it was, I think it was on Monday, we were due to leave on Tuesday, the Prime Minister rang Andrew and said to Andrew, I need you to come up to Canberra and help sort out some of this mess with me, with some trade deals. So he really apologised, but what he did was he sent a video to you. I'm going to play 15 minutes of it. It's a much longer video because he has a lot to say, but maybe there'll be time we'll be able to, Garima, maybe we can make this public available for others. So with your permission, Garima, I will show this, but I'm not sure where to go, how to do it. So if you could, you're going to help me. All right. Video. Yeah. to start from the beginning. Can we have some sound? Can we have some sound, please? We'll just stop it. Can we stop it? Wait, I'll just stop it and then we'll start again. Just 1 minute. Okay.
Hello everybody, I'm Andrew Robb and I feel privileged to have this opportunity, and I'd like to particularly thank Professor Raj Kumar for the invitation and for the organisation of what is, I think, a very important forum. I do apologise for not being there in person. I've had a matter arise at the last moment, and I've had to provide this video as a substitute, so I hope it does convey what I wanted to say effectively to this forum, and I thank you again for the opportunity to address you all in this particular way. I just wanted to share my own experience, if you like, with depression. I'm not an expert in any sense, very much a layperson when it comes to this issue, but for 43 years.
One whom both she and I know extremely well, and he was treated for the depression and has held most amazing positions in our parliament, and is now in Canberra working with the Prime Minister, and he feels better in the morning. So the black dog has lifted. So I mean, I can't tell you how important it is to have people like Andrew Robb talking about his stories. Because can you imagine a cabinet member from India being so open and frank about their depression?
Well, some of them display that in different ways.
Yeah, that's right.
Like slapping airline employees.
Like saying, that's right. So I think we're very proud to have Andrew as our chairman, and also he's very, very supportive of the work that we do and hope to do with you. So I now bring you Professor Chi Ang. Chi is the Health Scope Chair of Psychiatry and Director of the Professorial Unit at the Melbourne Clinic. He's Director of the International Unit, Department of Psychiatry, University of Melbourne, and he was based at St Vincent's Mental Health, where he still works occasionally. He's currently the co-director of Asia Australia Mental Health with me, and he's the site director of the WHO Collaborating Centre in Mental Health, St Vincent's, and the past Secretary General of the Pacific Rim College of Psychiatrists. He has a huge, wide experience of pharmacology, pharmacogenetics, clinical psychopharmacology of depression, bipolar and schizophrenia. When patients try everything, they go to Chi. Chi's often the person that deals so humanely and so wisely with very, very difficult patients. And I know this because he was my daughter's boss, who is also a psychiatrist. So, and she told me how fabulous he was as a doctor, but also as a leader in mental health. He's been an international mental health consultant for the WHO, CHOGM, Commonwealth of Nations, and Ministries of Health in several Asia Pacific countries. Chi's going to talk about now something that Australia and some other countries, including Canada and the UK, are starting to get really worried about, which is depression in the workplace. And for many of us who are working either in the corporate sector or government sector, we know that the costs of depression in the workplace are huge, and it's just something that can be treated really easily, and we are now going to hear a bit more about that. Thank you, Chi.
Okay, thank you. Good afternoon. Thank you, Julia, for your kind introduction, and I'm delighted to be here to participate in this forum to really acknowledge World Health Day, which has been declared by WHO. I think the first time that a mental health issue ever been declared as a World Health Day. So this is a very significant day. And as Professor Ian Everill has spoken, it is an immense burden globally for all nations, where it's going to be the single largest contributor of disability. And I suppose for countries, it's a bit, for me, surprising that given this, I suppose you can call this a tsunami of disability hitting all countries, that by 2030 is going to be the single largest contributor to disability, that we actually don't see a lot of action from the government side. And I guess where each government may feel the pinch is where it's going to hit in terms of economic output and productivity. So about 3 years ago, I was invited as a WHO consultant, but also as a consultant for the Commonwealth of Nations. Now, each year, all the health ministers of the 54 Commonwealth countries gather at one place to talk about a particular theme. And 3 years ago, the theme was mental health. And I was asked to give a presentation to 53 ministers to talk about, well, what's the relevance of mental health? And the key there was that if we talk about mental health as in terms of how we can best include social and economic inclusion of people with mental health problems, then it may be a very effective platform for us to elevate this to a national initiative and action. So workplace depression is really where I suppose this issue about how does it affect a country and in terms of its economy, in terms of its productivity, and also about how we are all affected by depression. But first, let me give you the definition of what is a healthy workplace. Now, this definition is actually from WHO, is one in which workers and managers, so both the employees and the employers, collaborate to use a continuous improvement process to protect, promote the health, safety, and well-being of all workers and the sustainability of the workplace. Now, you can break this down and unpack this. There's lots of ways that you can interpret this. But I suppose the key here is the well-being. We are not just talking about the physical health, but we're also talking about the mental well-being of workers. Now, the impact of globalization has really created a huge effect on the way the global marketplace, where we all work, and how that impact on our mental health. There's increasing competition, as we know, globally in the marketplace. The advances in IT, communication technology, we get perhaps 40 years ago, each company workers might have maybe at best 10 to 20 mails or papers they may have to look at. But each day, as you know, many of us may be hit by 100 to 200 emails that we have to respond to. There are more people living and working in overcrowded cities. There's longer commutes to get to work in difficult traffic, particularly in large metropolis like Delhi. There'll be longer working hours away from families. And in general, there's an acceleration of the pace of life. There's constant time pressure. So even if we have technology that is supposed to save us time, don't we all feel that we actually got less time on our hands? Which is such an irony. So really, all these factors are leading to a significant increase in terms of our workplace stress and also our mental well-being. So what would you sort of define a work-related stress? So one definition would define that work-related stress occurs when someone feels that the demand of their role are greater than their ability to cope with the demand. And if you have a prolonged and excessive exposure to these workplace stress, it can be a risk factor to develop mental health problems such as depression. And there's been a lot of studies and research looking at these risk factors that contribute to workplace mental health problems. And these risk factors pertains to both the content of the work, but also the context or where the work is. For example, if one of the greatest contributor of workplace stress is workload, where workers are experiencing long hours, no breaks, tight timelines, and really have no place to recover or recharge. On the other hand, if you have lack of work, or you are having a monotonous, unpleasant task that you have to do repeatedly and quite mindlessly, that can also create stress. If there is a lack of participation or control in your workplace, or a lack of support from your supervisor, that could lead to stress. When your work role is ambiguous, or there's conflictual demarcation of your work role with other workers, that can also create stress, or a lack of recognition of your work. Obviously, any discrimination based on inequity, for example, based on gender, race, sexuality, or even having a mental health problem could lead to discrimination. That can create a workplace stress. Bullying and harassment are obvious cause, and it can be a major risk factor. Poor interpersonal relationship with your co-workers or working under poor working condition is a major factor. Or when your workplace has poor leadership and there's lack of communication between the organization or the employees with their workers. Or when there's conflictual or conflicting home and work demands, that can lead to workplace mental health problems. Now the point is that this work-related stress is not a static concept. It actually is there is a dynamic interaction between the risk factors for work-related stress and how it would create a stress reaction. I actually might need Ian's one of these laser pointer. Okay. Yeah. So the risk factors would lead to kind of the stress reaction, both in terms of physiological, behavioral, emotional reaction, and social cognitive reaction. And if under prolonged stress, they could lead to long-term consequences, and these could be psychosocial long-term consequences, which would impact on mental health or cognitive or social behavioral health, but also physiological and physical consequences, such as cardiovascular disease. For example, we all know that under prolonged stress, or people who experience mental health problems are at higher risk of developing cardiovascular disease. And this would then all interact with the individual characteristic, whether it's based on gender, age, education, and other risks or vulnerability factors. So it actually quite a dynamic process of how it actually leads to mental health problems. Now let's look at some key facts. Workplace mental health issues, at least 1 in 4 people at the workplace will experience a mental health problem each year. Now this figure is staggering, but how many employers or organizations actually recognize this? Depression and anxiety are now the leading cause of long-term absenteeism or presenteeism, as it was defined when an impaired worker is at work, but actually has reduced productivity at work. On average, someone with untreated depression will need 3 to 4 additional sick leave a month. Now, if you calculate that, that's an enormous cost to any organization. So untreated depression and anxiety cause business, and it's been estimated in Australia, with a mere population compared to India's population, 24 million, it costs Australia $11 billion each year. Now, extrapolate that to India. Someone who's good at mathematics, maybe you'll tell me. In the UK, with 64 million population, that's a cost of 70 billion British pounds of lost productivity. Now, Beyond Blue is our national depression initiative, have really provided lots of guides in terms of what are some common symptoms of depression that we can all learn to recognize at our workplace. These symptoms may affect our feelings, so feeling overwhelmed, guilty, getting angry, frustrated easily, lack of confidence, being unhappy or miserable, indecisive, or easily disappointed. That can also be associated with physical problems. So, for example, feeling constantly tired, sick or run down, having aches and pains, sleep and appetite changes, or even weight loss or weight gain. At work, they may be turning up late. They may be finding it hard to meet deadlines. They start to withdraw from the colleagues. Colleagues might notice they start to rely on alcohol or sedatives. They start to take excessive sick leave, or started having difficulty concentrating or managing multiple or multitasking. So these may be clues for us to recognize that maybe one of our work colleagues may be having mental health issues. Now, PricewaterhouseCoopers is a leading consulting firm in Australia and internationally. They were commissioned to really conduct a study and provide a report called Creating a Mentally Healthy Workplace, to look specifically on the return of investment if we were to address mental health problems at the workplace. So in their cost analysis, if companies or organizations were to implement an effective mentally healthy workplace, organizations can expect a return of investment of 2.3. Now, I'm not an economist. There's economists in the audience. Will tell you that what that means is that for every dollar spent on successful implementation or action, you can expect an average of $2.3 in benefits gained by the organization. Right? Now, this was not done by doctors or the psychiatrists. This was done by the leading consulting firm in Australia. And I don't expect this to be any different in other countries. So, what are the benefits? They quantify it in terms of improved productivity by reduced absenteeism and reduced presenteeism, and also to reduce the number of compensation claims that can cause each organization enormous monetary burden. So, what did the PwC report recommend? That we need to start taking actions in workplace. The key recommendations are, first of all, we need to raise awareness and reduce the stigma. To talk about it, let's talk, is really the slogan of the World Health Team. It's a very useful way to start. And then, what's not in this step is that perhaps some way of screening, some way of recognizing that perhaps our colleagues may be struggling, they may be having some mental health issues. And then develop ways of supporting staff in mental health problems. And finally, to really create a positive working environment in which the employees would thrive rather than they've been burdened by work stress. So, in an ideal world, a mentally healthy workplace would have the following impact. It would encourage everyone to speak openly about mental health. It would support all employees, including those with mental health problems. Rather than discriminate them or having a prejudice against them, they would be supportive and in trying to help them to return to work earlier. It would also focus on activities that improve staff morale and engagement. And not surprisingly, if you do all this, it would, it would enjoy high staff loyalty. There will be a great higher retention rate, fewer staff turnover. And surprise, surprise, it will lead to fewer interpersonal conflicts and complaints and sustain high productivity. So we need to be able to promote ways of developing what are better, mentally healthy workplaces, which is not talked about often. Actually, this concept is not new. In fact, WHO published the World Health Organization Global Plan of Action on Workers about nearly 10 years ago. And in this recommendation, they propose 5 keys to healthy workplaces. The first key is to develop a leadership commitment and engagement. So The organization as a whole has to have good leadership to recognize this is an important issue. Second key is to involve the workers and their representative. Now, you can't make a decision about your workers without actually hearing what your workers' opinions and how they might impact them. Like the saying, nothing about us without us. Thirdly, there need to be appropriate business ethics and legality. This is obvious. Key 4 is to use a systematic, comprehensive process to ensure effectiveness and continual improvement, whatever process they put in place. And finally, the 5th one is sustainability and integration. It is not, this is just an additional part of your work program. It needs to be integrated and needs to be part of the core business of every organization. So if you follow the journey of... it's my last slide, thank you. If you follow the journey of from a healthy worker to becoming one that's symptomatic or at risk, then leading to mental illness, and then leading to sickness and absence. So this journey, there are various points that we can intervene. All right? At this point, we call primary prevention to create a mentally healthy workplace, then secondary and tertiary prevention, and to prevent the risk. And the Australian Mentally Healthy Workplace Alliance developed this evidence base. There are 6 key domains where workplace can address to maximize mental health and well-being. I won't go into this, but there are already well-established evidence and ways that we can address this in most organizations. So in Australia, we have a range of different awareness and education packages that are available that provides guidance and advice to both employers and employees to how to develop practical and flexible action plan to reduce workplace stress and promote better a mentally healthy workplace. And these are the range of different examples that I've shown you. So with that, thank you for your attention, and we hope that we can have an enjoyable, interactive session. Thank you.
It's now my pleasure to introduce Dr. Vibha Sharma, who's currently the Associate Professor of Clinical Psychology at the Institute for Human Behaviour and Allied Sciences, IHBAS. So I think we had Professor Desai here, and he said he had to step out quickly, but he'll be back. Dr. Sharma has made important contributions in the area of yogic exercises for various disorders such as schizophrenia, bipolar affective disorder, dementia and epilepsy. She's also widely published in well-resulted journals such as the Indian Journal of Psychological Medicine, Indian Journal of Positive Psychology and Advances in Anthropology. So over to you. And her topic today is the psychological interventions for treatment and prevention of depression. Thank you.
For generous introduction. Good afternoon, everyone. So let us talk about depression. That's the theme of today and this year, I think, because World Health Day has recognized this theme of depression. So I'm going to talk about talk therapies, the psychological interventions, psychological treatments, which we commonly know as talk therapies about depression. So in gist, I can say that simile I often use with my patients also, that psychological interventions or the learnings which they can learn through psychological interventions, the kind of support they can gain from it, like an umbrella. You cannot change the external stressors, you cannot change the internal stressors from your body or from the outside, but of course, like if the weather changes, you can have your own umbrella to prevent yourself. So the psychological interventions work not only for treatment, also for prevention. And that reminds me, while talking for depression, I'm really I can say I was disturbed for last 2-3 days, though like reports, newspapers are full of reports of suicide. Every day at least 2 to 3 suicides reports in Delhi newspapers. But this was from Mumbai 3 days back when a student, 23 years old graduate student, committed suicide, hiring a room in a 5-star hotel and then making a live video of it and posting it on Facebook. So where are we leading? Where our society is leading? Means committing suicide and making fun of it, or was it a cry for help which no one could identify? He wrote that he was into depression, he was into drug addiction, and probably no one was there to help him. Probably all of them, all his friends and family were thinking that he's into some bad habits or something. So there was probably no one to talk to. If like within time, if it could have been recognized, if he could have referred to some mental health help, he could have saved. A young life could have been saved. So let us begin. Coming to the psychological, theoretical part, because Julia has already said that I'm going to just take 15 minutes and then later we can talk in detail. So I'm going to just give you a brief description of psychological treatments which are available. So before starting that, a brief introduction to various psychological theories which are prevalent, how they explain about depression. So the common psychodynamic theories we know, they talk about depression as they focus more on unconscious processes, we know, and the feelings, thoughts which are mainly unconscious, and pathological motivational patterns, pathological relationships which are based in unconscious mind. While cognitive theories focus on pathology of belief and thoughts, they say that it is about the faulty thought patterns, faulty beliefs. Another theory, major school of thought, behavior theorists, they say that depression is a learned behavior, and this learning takes place because of faulty contingencies, or you can say the faulty reinforcements which person gets in life. Interpersonal theory, at the other hand, talks about that depression is mainly because of the problem into relationship of a person in his interpersonal environment or in his interpersonal relationships. At the other hand, there is a difference in humanistic existential approaches where these approaches are person-centered. So they talk that there may be a lack of personal resources in a person, or he is not able to identify those resources, the environment is not that supportive, so the person develops depression. We all know about stress diathesis model also, that talks about stress and how vulnerability leads to stress-related disorder, and depression can be one of them. We just heard about stress at workplace, how it may lead to workplace depression and other mental health problems. And theory of, which is one of the recent theories, is learned helplessness, that a person feels helpless and that's why he or she develops depression. While talking about the interventions, psychological interventions, the most common intervention, which is one of the common one, which is most popular and which is supposed to be most evidence-based therapy or intervention, is cognitive behavior therapy. It is found to be as effective as pharmacological treatment, but we feel that if like both are combined, the results are excellent. So when pharmacology and cognitive behavior therapies are combined, especially for depression, the results are promising. It is one of the most effective therapy. So it is based on the cognitive triad described by Beck, that he assumes that depression is a result of when a person focuses on main three things, like negative views towards himself, negative views towards the world, and negative views towards the future. So these therapies are like very discrete, structured, time-based therapies, and they take educative approach where through collaboration between client and therapist, the person with depression learns to identify or recognize his or her negative patterns of thinking and how these thinking or belief are affecting his current life and symptoms. And then the person develops skills to identify, monitor, and challenge those irrational or negative thoughts. And with the help of therapist, he learns the appropriate coping skills and tries to change or restructure those negative thoughts. So this is in brief about cognitive behavior therapy. Cognitive behavior therapies can also be used in group situations where like in a hospital setting, because these groups may also help as self-help groups where different people can talk about their own situation, their own problems, and then they can learn coping strategies from each other, and the therapist can work as a facilitator, and he can come out with some coping strategies which in group are easy to learn, and these are also good to learn social skills with these patients. Coming to the behavior therapy, in behavior therapy much has not been talked about depression, but basically, as I said, they think that it is again a learned behavior. Faulty learning has taken place. Probably good positive reinforcement was not provided to a good behavior, or faulty positive reinforcement was provided to the negative outcomes, and negative reinforcement was provided to some good behaviors. That's how good behaviors and good feelings of the person, that's how person develops these kind of negative feelings. These are maintained by negative reinforcement. So a person, when he is happy, he is not getting positive reinforcement for it, or he is getting negative reinforcement for it, so he learns not to express the positive feelings or positive behaviors. So this therapy talks about behavioral activation, where a person can encourage, where the therapist encourages the person about task oriented and task focused behaviors, and person learns to come out from that negative reinforcement situations. Coming to another approach is problem solving. That is very simple approach. Therapist helps the person to identify the problem areas, and then because it is assumed that some persons don't know how to recognize the problems of their life and how to solve stepwise those problems. So such persons may feel helpless, may feel depressed because of the situations, problematic situations in their life. So here therapist helps the person to identify the problem, to divide it into different tasks, and the person learns how to solve stepwise the problem and reach up to a solution of that problem. Interpersonal therapy is another very popular and very important approach for dealing with depression. Especially this theory assumes that person having interpersonal problems with the environment, with other persons in his or her environment, like the close relations, friends, he is not able to deal effectively his interpersonal relationships. That's why probably the person is having problem of depression. So this IPT or interpersonal therapy focuses mainly on the current relationships, not like other therapies which focus on the thoughts, or which focus on unconscious interpretations of relationships. Rather, this therapy focuses on current relationships, and again, it is a time-limited therapy, and collaborative efforts from therapist and client are required to identify the effects of problematic areas related to interpersonal conflicts, role transitions, grief, loss, and social skills, etc. And client seeks help to learn how to cope up with these relationships and how to develop good, meaningful, purposeful relationships in life. Humanistic approach, as I was talking a little different, this approach is a human-centric approach, we can say. So it talks about identifying the human resources in a person. It assumes that every person has some resources, and provided a good, genuine, empathetic environment, that person can come with own solutions. Every person has an ability to solve the problems. Every person has the ability to fight depression. So the approach is that those positive things have to be bring out, those resources have to be discovered, and person has to practice those. Couple therapy or marital therapy is also used in the cases of depression, where the key cause is the relationship issue. Psychodynamic psychotherapies we were talking, where like the base is, where the understanding is that the issue is in the unconscious mind. So these are generally the talk therapies, or now these are not used much, where the person is allowed to ventilate or in taken into the hypnotherapy kind of situation, and the unconscious patterns are identified and resolved. Another very important therapy which is not talked much about in the literature is supportive psychotherapy, which also deals with the current situations, current circumstances, and it is used to treat depression by improving self-esteem, psychological functioning, and adaptive skills. So basically it supports the psychological or ego functioning, and person learns adaptive skills with the help of therapists. So these were some of the approaches of treatment. Now very quickly I would like to highlight a few approaches for prevention, because these are very important. Just 1 minute more, please. The approach is positive psychology, because all other approaches focus on the negative effects, negative feelings, while positive psychology advocates about the prevention and bringing out the positive things in a person. Another which is being very popular nowadays is mindfulness-based cognitive therapy, where a person learns to focus on the present thoughts which are going on, and if there are negative thoughts, person learns how to negate those negative thoughts and concentrate on the present. Another approach which is especially for the Asian countries in East, spiritually oriented psychotherapies or spiritually augmented CBT, where spirituality is being asked to introduce into the life, so a person can find meaning in the life, in the problems, and he can resolve his problems through learning some of the basic values and basic values of life and basic skills in life, positive skills. So this is all. Thank you.
Well done. Thank you. Turn to ask questions. And if I could ask you to think about your questions beforehand and identify yourself and not make it a long story. Just get to the point and ask the questions. We've had a number of different people talking already today, and I'm sure there are many questions you have. So I think we can take 3 or 4. So please just keep them short, identify yourself, and let's go. Thank you. Who'd like to kick off the questions? Okay, so, and then the gentleman in the front. Okay.
Hello everyone, my name is Chavi Mittal. I am a research scholar from University of Delhi. I would like to speak to Professor Chi. Sir, actually I would like a comment from you from the workplace scenario. Basically what happens is, if there is an employee who has some mental illness, so ideally the workplace, the employers are not supposed to fire them on mental illness or any illness, medical grounds. So what they do is they harass the person and force them to leave. So what needs to be done in those cases?
I think that you raise a very important issue that perhaps used to happen a lot in workplaces in Australia. I can only talk about the Australian experience. But we now have a work, it's called Fair Work Australia. It's actually a commission that's actually set up that looks at these cases in particular, where an employee who suffer any illness, whether it's physical or mental illness, cannot be discriminated, or they cannot have their employment terminated on those grounds. This is very clear, it's written in law. And if they do, they actually broke the law, and actually they will be penalized and even fined. So I think that it's important that as part of is raising awareness, we should also make sure that we also raise the importance of workers' rights. And that was part of the reason why 10 years ago WHO produced that guidelines to make sure that we protect the rights of workers, because it directly impacts on their health and mental well-being. So I think that it's something like that will be necessary to where it's put into policy and put into legislation that could actually protect the rights. But you know, it's a bigger discussion and more kind of social political, I think, implication for that.
a good beginning point, and we're delighted that this has happened, is that the new Mental Health Act has just been passed in your parliament, and that's a great beginning point. So, so there are consequences for those who break that act. Yeah. Okay, the gentleman. Yeah.
Hello everyone, I'm Banu Prakash. I'm a counselor and psychologist at General University. I would like to understand about geriatric depression, and my specific question is intervention for geriatric depression is different from depression suffered in other age groups? Because I believe some element of depression is part of the aging process, and how much therapeutic push is too much or too little. Right? I would like to understand.
Well, perhaps if we have both of you talking, because I think you'll come from different points of view.
Any of the speakers?
Definitely geriatric depression is slightly different from adult population's depression because there might be many biological factors, especially because of the aging. There might be some other medical conditions which may lead to secondary depression. And there are some socio-cultural factors, especially the loneliness, what we call emptiness phenomena, which is specific to the aging. So in geriatric population, I am not much aware about the medicine, which my psychiatric colleague can answer. But the therapies are also a little bit different. We have to tailor-make the therapy according to the age of the client, seeing the socio-cultural or psychosocial circumstances of the person. And of course, CBT works if there is a psychological sophistication. Otherwise, supportive psychotherapies are very helpful. And mindfulness and spiritual psychotherapies, especially in Indian context, are found to be very, very effective with geriatric population.
I agree fully with Professor Sharma. We must also fight ageism, all right? Just because somebody is an older person doesn't mean that they should be feeling miserable or depressed or it's part of aging. This is a very common misconception, and you need to be able to raise the awareness that it is not normal for an older person just to feel miserable, okay? Even though their circumstances might be challenging, which needs to be addressed. But very important to ensure that they get full access to treatment, proper assessment, and proper diagnosis so that we can provide them the full range of biopsychosocial treatment. And I also agree that sometimes in geriatric depression, it may herald a pre-existing or an emerging physical problem, for example, dementia as well, that sometimes they can be preceded by depression. So they need to have proper assessment.
Yes.
Hi, I'm Vani and I'm a research scholar with Ministry of Human Resource Development. My question is about prevention and intervention for something as new as Facebook depression or a depression that's caused by use of social media, because the thing is that with inadvertent use of technology, the assumption is it's going to homogenize cultures, right? And having said that, that's something which is still kind of being discovered and explored, and the question is open to any one of you. So if you would like to make a comment on it, about what we're doing for across generations. It's not generation specific, but I think it would probably affect young people more than the rest, given education and other kinds of productivity that are at risk. So any kind of depression that is caused by social media or social networking use particularly.
You go first?
Yes. I think social media is used mainly if we see today that need for affiliation is generally high in such people. And what is going in this fast pace of life, people don't have actual friends. They have more virtual friends, so they need, they are searching for that affiliation, that affection from the virtual friends, from the friends of social media, not having the actual friends. So support from friends and family is getting less and less, and Facebook friends might be, we don't know whether these are actual real persons or not, because many of them are having fake identities, and when a person is in need of support, so they are not coming actually. So what preventive methods can be used are especially to encourage our youth to go for social outings, to have at least a few good friends. they should learn to give support as well as to seek support from the society, from the family. So these are some of the basic skills which are missing mainly from the youth and the adolescents. So these are some of the things they should know: how to work in a team, how to play in a team, and how to get and seek, means how to give and seek social support. That is it.
Thank you. So everyone here always knows that your friends on Facebook are having a much better life than you are. Yeah, it's a given, right? For children who have not been brought up with critical thinking skills, this is a real issue. And I know in Australia that the curriculum now is looking at the way to analyse what they're seeing on social media. So giving them skills to understand that what they're seeing on social media may not be reality. And exactly what you're saying, you don't even know if those people are real people. But the evaluation skills are highly important. And critical thinking is a skill that somehow has been dropped from a lot of the curriculum that we have. And I know in India, people used to talk about those sort of critical thinking skills. We've dropped that. And now in Australia, I've noted that the curriculum is now bringing that back and thinking about how do we teach our kids to evaluate whatever they see, what's fake news, what's fake friends. Okay. Yeah. Next. Any other
Last question, please.
Last question, please. Can we have two? Because we had two that we... Yeah. Okay. Yes. Yeah.
Good evening, my name is Joyshi. I'm a student from UNL Global Law School.
Based on the statistics presented today, we saw that women are more prone to depression as opposed to men. My question is, why is it so?
We need a whole lecture on this.
But there are clear reasons in terms of one main reason is inequality. Women throughout the world are more at risk of disempowerment. They're more financially disadvantaged. They also have lower social status. But that's a kind of a social, political kind of risk factor. But there are also biological factors as well, particularly women who, after birth, because of hormonal changes, are at a very high risk of developing postnatal depression. And also around menopause as well, for a variety of other reasons. So there are many complex reasons why, but the statistics are there. So we really have to pay more attention. And in fact, there is, in development terms, if we help women to improve their mental health, because of the role women play globally, we actually can have a greater impact in terms of productivity, in terms of well-being of families, and particularly the mental health of children. Very well proven evidence now that if you look after the mental health of women and mothers, the long-term prognosis for their children actually improves.
Do you want to say something? Yeah. The gentleman at the back, the final, yes, thank you.
Hello.
I'm sorry.
The thing is that the workplace differ from person to person. Some people work in the industry, that is the workplace for them. The farmers who work in the field, that is the workplace for them. And in India, there were very instances that the farmers who couldn't sow their crops and they were under crisis and they committed suicide under high level of depression. So the thing is very simple, that the what sort of the treatment can be provided to them. Thank you.
You're absolutely right. And in fact, you think it's just India, but the highest rate of suicide in men in Australia are people living on farms, the rural workers, because they see when things go bad for them, they see no other way, and they're the ones who, on their shoulders, they're looking after their families, etc. So that is a real problem. So the way that we've been working in Australia is to actually reaching out to those guys, to establishing things like men's sheds, And that's a place where men can go and make things together and talk. So it's sort of very, like they might be making toys for underprivileged children, or they might, but they actually, the purpose of this is talking. So it's just it's a common problem. It's not just India.
I think that's really true. I think the studies have shown that one of the risk factors is people living in rural areas, and also people who face financial difficulties. So you have those cumulative risk factors, you're going to increase the chance of depression and suicide. And also talking about suicide in the rural areas, there's been also a very close correlation between suicide in women in rural areas and the availability of suicide, means of suicide, the use of pesticides, for example. So one very effective ways of preventing suicide is actually to control the use of pesticides. It's dramatically changed the suicide rates in countries like China and India.
I think that the young gentleman with the red shirt, I think he deserves it. So last one, because he really deserves it. Yeah, go. Quickly, as long as it's a quick one.
Good evening, and my question is to Dr. Vibha. You talked about various forms of psychotherapy, all of which have been developed in Western countries. Do we have any indigenous or Indian psychotherapies to treat individuals?
Not the indigenous therapies are coming, but the main the forms which are coming are the Indianization of these therapies, especially putting up the content, Indian content, especially when I was talking about spiritually oriented psychotherapies. These are mainly Eastern-based therapies. So putting up the content from Indian texts or Indian mindset to the framework of those Western therapies. So the framework remains the same, like for example CBT, or as we say that the oldest CBT prevalent in the world is from Srimad Bhagavad Gita, which comes from India itself. So therapies are not like, framework is the same. The content you put for challenging the thoughts or for reconstructing the thoughts or for any other therapy, that can be culture specific.
Thank you. And thank you to the panel.